All right, everyone, we're going to go ahead and get started. Dr. Warren will be here in just a little bit. My name is Dr. Divya J. I am one of the two reconstructive urologists at University of Rochester Medical Center. Dr. Warren is the other. We both see both men and women, and we both treat men and women and, are able to help you with any of these issues that may come up. We both have found a lot of use in doing community events and reaching out to and just, letting people know the services that we provide. So if you have any questions, if you can put that in the Q&A, we will be sure to answer all of them. I also want to just thank Ms. Tahir and Mark Geisenberg, who's helped us with putting together this event. We appreciate it very much. So let's get started. And like I said, Dr. Warren will also be joining us. We wanted to talk a little bit more about incontinence. So the idea of being continent is having control. And we are specifically talking about urinary incontinence. You can have, of course, fecal incontinence as well. Incontinence is not having that control of being able to decide when you want to go to the bathroom and leaking urine unintentionally. So we'll talk a little bit about different types of urinary incontinence. I know a lot of times you think, oh my God, I'm leaking urine, and you think that's it's horrible. But for us, it's actually a very complicated issue. There's many different types of incontinence. We can talk a little bit about risk factors, what our evaluation of incontinence is, and some non-surgical treatments and surgical treatment options that we might be able to offer you if you're a good candidate. So talking about urinary incontinence, it's a complaint, like I said, of any involuntary leakage of urine. Up to 40% of women and 20% of men can experience this. It's the number one reason why patients actually go to nursing homes, is not having voluntary control. You can have up to 80,000 surgeries a year. And, while the economy crashes, if you want one place to invest, it's the adult diaper industry. It's incredible, up to $20 billion in healthcare costs for treatment of urinary leakage. Risk factors: smoking, obesity, diabetes, type of fluid intake. So things like caffeine, sodas, other bladder irritants. Pregnancy, of course, stretching out the pelvic muscles. Age and menopausal status. We see a big spike in incontinence after menopause. Urinary tract infections, and any type of prostate surgery in men. Only men have prostates. It is a very embarrassing topic. It takes a lot for women and men to come forward and talk to their doctors and seek help for this. And, a lot of times patients tell us that they were never asked, and they always thought it was a normal part of aging. So they didn't think there was anything that needed to be done about it. There's also people who think that incontinence cannot be treated, but that's not true. There's a lot of treatment options, and we can go over those together today. On the other hand, physicians and primary care doctors are also embarrassed to talk about incontinence, sometimes feel unprepared and uncertain who can be referred and who should not be referred. So again, we're here to just open up the field and just talk to you about different types of evaluations and treatments for incontinence. It is something that can affect people in very severe ways, causing skin ulcerations, sleep deprivation, sexual dysfunction, work absence, disability, social isolation. And I've definitely seen all of this in my practice as well. I'm sure it's something that people on this call may associate with as well. So talking about bladder anatomy, on the left-hand side is the female bladder anatomy. On the right-hand side is the male bladder anatomy. So let's talk about what makes you continent. In females, it's this striated sphincter, this muscle right here, that helps basically almost like a blood pressure cuff, holding your urine internally. In the female, there's also two other muscles that work like a hammock, that work like this, so that helps with maintaining continence. In the male, there are two of these sort of blood pressure cuffs. One is this structure right here in the middle that looks like an apple core is the prostate. And you have one sphincter where the prostate meets the bladder, and you have a second sphincter where the prostate meets the urethra. And both of these work like blood pressure cuffs. They're around your urethra and they squeeze it and they remain squeezed tight. And when you're ready to go, they relax and they open up. So this is again male pelvic anatomy cut sideways. Right in front here is the bladder. Below that is your prostate, and you can see your sphincter muscles over here. So the prostate in men can lead to what's called benign prostatic hyperplasia. Your prostate can grow as you grow, so does your urine, your nodes. Just trivia. 50% of men between the ages of 51 and 60 have benign prostatic hyperplasia. Your prostate is grown large, and 90% of the men over the 80 can have this issue as well. So let's talk a little bit about urinary incontinence. And when I think about this, there's two main types of urinary incontinence. One is stress, and the other is urge. In stress incontinence, I think of it like the tie at the end of your bag has become loose. So when you apply any pressure on the bag, you leak urine. There's very little tone or tightness in the urethral sphincter. And this often in women is because of childbirth and any kind of strain in the pelvic floor. In men, this is oftentimes because of prostate surgery, any type of prostate surgery. Urge-related leakage can happen very commonly in men and in women. In women, we do see a big spike of this around the time of menopause. We think that it could be because of vaginal receptors and the lack of vaginal estrogen. However, it could be because of recurrent urinary tract infections or any kind of bladder irritants. For men, urge incontinence is often because they're fighting against a big prostate. When your bladder has been sort of pushing and struggling to empty against a big prostate, you can develop urge incontinence over time. There's many other reasons for bladder overactivity and urge incontinence: strokes, multiple sclerosis, bladder cancer, or bladder medications related to bladder cancer that can irritate the bladder, other chemotherapy medications, etc. And then there's other more rare, more complex type of incontinence. So retention, people who are walking around with a glass more than half full. And if your glass is half full, anytime you drink water, it's going to spill over. Neurological issues or functional issues. And we can talk about these briefly, but if you fall into one of these categories, you probably need a little bit more evaluation and a little bit more detailed one-on-one time. So like I said, the most two common are stress and urge. So over 40% of incontinence in general is stress, which is with laughing, coughing, doing jumping jacks, going from a sitting position to a standing position. That's stress incontinence. That's the tie at the end of your bag being too weak. Or mixed incontinence, where you have some stress and also urge, which is your bladder being like, let's go, let's go, let's go, let's go, let's go, let's go. So let's talk a little bit about stress first, and then I'm going to hand it over. Dr. Warren has joined us now, and he'll be talking a little bit about urge, and he'll talk a little bit more in addition about male incontinence, which is a little bit different. So stress incontinence is urine loss with increased stress on the abdomen, with laughing, coughing, sneezing, exercising, yelling, I guess, lifting, bending. And like I told you, so this is the tie at the end of your bag that has become loose. So general treatment options, behavioral changes. You can use what's called a pessary. I'll go over some of these: Kegel exercises, impressa, and surgical treatment options. So let's talk about these in more detail. So non-surgical treatment options first. The first are just simple behavioral things that you can do right away. Making sure your bladder is empty. If your bladder is empty, you don't have anything to leak voluntarily. So there are some patients who come in and say, oh, I don't pee during the daytime. I hold my urine because I have such a stressful job. I'll tell you, nurses and teachers are the worst. I don't know why, but they hold their urine all day long, and then they leak because their bladder is sort of not trained properly. So trying to void every 2 to 3 hours, is going to keep your bladder in a healthy, level. Try to keep your fluid volume. Some people require more fluid than others, but in general, if you stick to this 48 to 64 ounces, that should be good. If you are overweight, if your BMI is over 25, you want to try to get that down to a normal BMI, because imagine if you have a loose tie at the end of your bag, if you apply more pressure on your bag, you're going to leak more. But if you apply less pressure on your bag, you're going to leak less. Smoking and associated issues are not just cause incontinence, they also really complicate the treatment of incontinence. So I strongly recommend stopping smoking, but not just that, it's the single best thing you can do as far as your health and your community or the people around you. A contracted pelvic floor with increased abdominal pressure can also, so those are some treatment options. So a pessary is this sort of silicone device that we insert into the vagina. I would say about 60 to 70% of patients love pessaries. It is, but some other people find it quite uncomfortable and it doesn't work so well for them. We come in, it's actually a little bit of a longer appointment, but you would come in and we have 7 or 8 different types of pessaries. This one is called a ring pessary. It works the best for incontinence. We also use pessaries for what's called prolapse, which is when there's a hernia in the vaginal area, things up sort of pushing down. But the pessary would need to be cleaned out at least every 3 months. There are some patients who take it out and clean it themselves and put it back in. But there's a lot of patients who come to the clinic and we do it for them. It is a non-surgical option. And some people maintain it for the rest of their life. Of course, if you're going to have intercourse, you will need to remove that pessary prior to intercourse. So what the pessary does is it increases the urethral closure pressure and it stabilizes your urethra. And this is what a pessary looks like on the right of the screen. This is sort of an over-the-counter option. This is, a lot of people may be familiar with this brand Poise for pads. They make a lot of pads and incontinence products. They've come up with this sort of over-the-counter pessary, if you will. Comes in 3 different sizes and it looks like almost like a parachute. And it does the same thing. You can insert it yourself in the vagina, just like a tampon. And it again applies some pressure against the urethra to increase pressure to stop the leakage. And this is how it works. You can see on the right-hand side, this in the vaginal canal, this sort of parachute-like structure going in here to apply pressure against the urethra to prevent leakage. Obviously, this would need to be removed for intercourse. Pelvic floor physical therapy is one of the most powerful things that you can do. You can do these Kegels at home, but you can also go see one of the pelvic floor physical therapists. We have at least 3 or 4 in Rochester, and then we have a few in Canandaigua. We have some in Bath. We have some in the southern tier. We have some on the east as well. These are not just regular physical therapists. These are people who have spent time doing extra courses in the pelvic floor. Your pelvic floor is a big network of muscles through which the urethra, through which the rectum, through which the vagina actually peers through. And strengthening those muscles is kind of, what they work on with you and give you exercises to do that. Now, if you don't have the time, or, there's some insurance companies that don't actually pay for pelvic floor physical therapy. So if you fall into one of those categories, there's also devices that you can buy on Amazon that you can insert in the vagina. And using an app, you can do these Kegels yourself. For men, you don't have vagina, so you can't do that, but you do the same thing in what's for post-prostatectomy urinary leakage. We also recommend pelvic floor physical therapy. And for men, I often recommend starting with sort of squeezing the entire pelvic floor, including the anus. And that helps. And I describe it like you're trying to lift your penis off the ground without using any hands. And that's how you would represent a Kegel exercise. The other way to think about it is if you are peeing and somebody knocks on the door, the muscles you would use to kind of contract your urethra to strengthen those muscles. So unfortunately for stress-related leakage with laughing, coughing, exercising, doing jumping jacks, there really are no medications. If somebody is giving you medications for this, this is not actually FDA approved. It's not in any of our guidelines. This is really an anatomical issue. So unfortunately, there aren't any medications that can work with this. Okay. Let's talk a little bit about surgical treatment options, and then I think there is a question here, so I'll come back to that. And one question. Okay, so let me just finish this, and then I'll come right back to that question. So let's talk about the surgical treatment options. So we have sort of maybe 2 or 3 surgical treatment options. This is what's called a urethral bulking agent. There's many different types of these over the years. These are largely all developed in Europe. In Europe, there aren't mesh slings, so people really focus on developing these. This is the newest one that we are using now. It's called Bulkamid. It's 97% water and 3% polyacromide gel. So to us, it looks a little bit almost like hair gel. It's a very straightforward procedure. You come to clinic. It's not even, you don't even have to be asleep for this. If you want to be asleep, that's fine, but this is something we can do awake. And we inject this material on either side of your urethra to almost create like cushioning or like a dam to sort of bulk up or close up the urethra. Small risk of bleeding, small risk of developing a urinary tract infection, both of which are treatable. There's about a 25% chance that immediately after, patients may not be able to pee all the way. And in those patients, we place a small catheter, empty their bladder, and that essentially opens up the bulking agent almost like clay. And people are able to pee just fine. The success rate for the bulking agents are about 70% at 7 years. And this is all data out of Germany. This is where it was developed. And I would say this is a very, safe procedure. There isn't like an implant that's in your body for the rest of your life. The mid-urethral sling or the mesh sling is considered the gold standard in treating stress-related leakage. Okay, this is not the type of mesh that you read about on TV, or you people are like, oh, call your lawyer, etc. This type of mesh is FDA approved. It's perfectly legal. The type of mesh you are thinking about on TV is actually mesh for vaginal prolapse, which is a different disease condition, almost like a hernia in your vagina. Okay, so this type of mesh is perfectly legal. Again, it's considered the gold standard in treating stress-related leakage in women, not in men, in women. This is specifically in women. And it is about a 20-minute to 40-minute procedure. You go home the same day. For 6 weeks, we ask for no heavy lifting, more than 10 pounds, no intercourse or nothing in the vagina. We see very good results with this, over 90 to 95% results, with resolution of stress-related leakage, laughing and coughing. I don't really offer this to smokers because we do see an extremely high rate of complications in smokers. And I have removed a lot of mesh from smokers, so I have stopped offering it to patients who smoke. But in patients who are non-smokers, this is an extremely, extremely good option. Now, in patients who are mesh averse or who have failed a mesh, we can actually use a piece of your own tissue, like fascial tissue, and make a sling as well. That's called a fascial sling. So that's another option. So like I explained, the transvaginal mesh lawsuits are all for prolapse. You don't really, you may see it in this realm as well, but this is perfectly FDA approved. Like it says on that slide here, the FDA excluded these 2 types of mesh because we really don't see as many problems as we do with the vaginal prolapse mesh. Okay, let me just answer these 2 questions, and I'm going to have Dr. Warren take over. One of the
questions I can cover when we talk about overactive bladder.
Okay.
The second question was, are there any surgical treatments recommended for patients who have future plans for pregnancy? I'm assuming they are. focusing on stress incontinence.
On stress incontinence, right? So that's a really good question, because in, like this person has pointed out, in patients who are going to be pregnant, we do not like to offer them the mesh sling, but the Bulkamid, the bulking agent, is a perfectly reasonable option, and so is a pessary, and so is pelvic floor physical therapy. Those would be the options for somebody who is planning to get pregnant. All right, Garrett, so I'm going to say we answered this one, and then do you want to take over?
Hello, everybody. My name is Gareth Warren. A pleasure to be here this evening and a colleague of Dr. Ajay. Sorry for my slight delay, just coming out of the operating room and here to wrap up our presentation. There was a question that asks about what causes an overactive bladder in young women who haven't reached menopause yet, nor have experienced childbirth. The symptoms primarily include inability to hold urine or experiencing intense pressure and waking up 2 to 3 times at night to void with restricting fluid intake before bedtime. By the end of my conversation, of my portion, when we talk about overactive bladder and urge incontinence, I hopefully would have covered that, and we can kind of circle back at that question. Dr. J, would you like me to share my screen, or can you keep like we're doing? Perfect, thank you. So for urinary urge incontinence, just by definition, is unintentional urine loss with a strong urge to urinate. So it's a situation where you are not necessarily in a socially appropriate, or you are in a position that you're ready to urinate and your body is telling you have to go, and you have to go now. And for many women or men, that's a situation where you cannot hold it enough and you actually leak urine on yourself. When we talk about terminology such as urinary urgency or urinary frequency or urinary or nocturia or overactive bladder, those are all terminologies that fit underneath the umbrella of overactive bladder. And so overactive bladder includes urinary incontinence, urgency, and then frequency, including nocturia. And just by definition, nocturia is a situation where you urinate or you feel the urge to go to the bathroom during the course of the night and wakes you up from sleep. All of these forms of what we call irritative lower urinary tract symptoms are all factors related to overactive bladder. Next slide. So let's talk about the different treatment options for urge incontinence, or even just in general, we can call this included overactive bladder symptoms, again, including urinary urgency, frequency, and urge incontinence. And keep in mind, you don't have to have urge incontinence to still have treatment options. You can have just urinary urgency and frequency. There are both surgical and non-surgical management options. Surgical include percutaneous tibial nerve stimulation, which we'll go over each of these, Botox injections or bladder Botox injections to the bladder, and then lastly, sacral neuromodulation. Those are all advanced therapy treatment options for help for treatment for overactive bladder symptoms. And then we first begin with non-surgical options, behavior modification, Kegel exercises to some degree, and then medications to be able to support. So let's talk about some of the non-surgical treatment options. Time voids, voiding every 2 to 4 hours. I think as Dr. Ajay mentioned, you can't leak what you don't have in your bladder. So if you have a situation where you're going to the bathroom on a consistent basis, we recommend patients go to the bathroom once every 2 to 4 hours. If you're able to empty out, and 2, you don't get to the point where you feel like you gotta go and you have this really strong urge. Toileting by the clock and not the urge. So that goes in the idea of you continuously emptying your bladder on a regular basis and not waiting until you feel that urge. Relaxation techniques. So there are many individuals who have triggers. It could be cold weather. It could be washing their hands in it or washing dishes in cold water. It can even, particularly in our climate, stepping out into a cold climate condition, or even driving up your driveway or putting the key into the door to be able to come into the house and then get that instant urge to have to go to the bathroom. And learning different techniques to be able to hold that, realizing that you do have time to get to the bathroom, stress management techniques and ways to be able to relax your whole entire body and framework to distract you until you can get to the bathroom to urinate. And then lastly, fluid normalization. We usually recommend no more than 60 to 80 ounces at max, depending upon your body habitus and your weight, but usually between 40 to 60 some odd ounces per day are fluids. And for some patients, it's the type of fluids. So staying away from bladder irritants, such as coffee, caffeinated beverages, which I'll talk a little bit more a little later in another slide, but staying away from bladder irritants that can make you go to the bathroom, and then the quantity of fluids that you're intaking. So when we talk about avoiding bladder irritants, as I mentioned, caffeinated beverages, carbonated beverages, sodas or pops, caffeine, coffee, tea, alcoholic beverages, beer and wine, these are all bladder irritants. Uncontrolled or diabetics or patients with diabetes can have issues with urinary urgency and frequency. There is some known entity that urinary symptoms in the bladder can be impacted by smoking, and so avoiding and having smoking sensation, as well as lastly, particularly with nighttime issues, there is a direct correlation with how one is able to sleep and controlling for obstructive sleep apnea, which is stopping to breathe while you're sleeping can trigger increased urine production and can lead to what we call nocturia, as I mentioned, getting up in the middle of the night to go to the bathroom. So one of our, that's our first line therapy when we talk about behavior modification. And then we move on based upon our guidelines. When we talk about second line therapy, it's medications. There are oral medications that you can take by mouth, usually with very low side effect risk profile. Some of these medications can cause dry mouth or constipation. There are several different medications underneath anticholinergics. We just listed one, for example, Sanctura, but there can be a tremendous number of commonly utilized anticholinergic medications that we can be able to give on a daily basis. And then there's also another form of a medication called a beta-3 agonist. These all work on the bladder to help relax the bladder, to prevent the bladder from being hyperactive, thereby cutting down urgency, frequency, and urge incontinence. So these are medications that can help cut down as a second line therapy for urinary symptoms. Now let's talk a little bit more about the surgical options. So the first, and I would say overall, probably the least of our advanced therapy treatment options that are employed is something called percutaneous tibial nerve stimulation. So percutaneous tibial nerve stimulation is essentially almost like an acupuncture needle that is inserted into the tibial nerve, which is at the base of the foot at the ankle. And that is connected to this constant electrical stimulation. And that pulsatile, or that constant current of electrostimulation, stimulates nerves that go directly to the bladder, and from there can help control urinary symptoms. It is usually an outpatient procedure that is done while you're completely awake. It's an office-based therapy. I shouldn't say procedure, but just therapy that can be inserted. As you can see here in our model, you can be able to read a book, usually lasts for roughly about 30 minutes to an hour, generally taking up to 6 to 12 weeks as an initial in sessions, and then you need booster sessions or follow-up sessions every couple of weeks thereafter. And so this is a therapy where you can be able to come into the office and have this done. And again, you're completely awake, again, with the goal of trying to improve your urinary urgency, frequency, or urge incontinence. Next is a procedure that we can do in the office or the operating room, and this is called bladder Botox. Botox is being used in a variety of different ways in the medical world for treatment of various different elements. But here in this situation, the Botox is able to be injected directly into the lining of the bladder, and that helps relax the bladder to prevent urinary urgency, frequency, or urge incontinence. So that's what it's approved for. There is very low risk of bleeding and infection during these procedures. Takes roughly about 10 to 15 minutes at max to be able to do in the office, and you go home, you're completely awake during the procedure, and it's usually well tolerated. The therapy is only good for roughly about 3 to 6 months. It does wear off with time, and then you have to have supplement interventions where you come back and have additional Botox therapy given. Very low risk of bleeding, infection, or injury to surrounding structures. However, it can have a very low risk as well of temporary urinary retention. And that's a situation where your bladder it works so well that your bladder gets quiet and then it kind of stops working and you have to use some form of a catheter. Again, very rare, but it can occur. Next, this is a procedure. These are all procedures. Actually, this is what I just finished with doing just today is sacral neuromodulation, or what we call a different couple of products. Exonics or Medtronic both offer these products as an intrastem. But what this is almost like a pacemaker to the bladder. It's electrical stimulation that stimulates the nerves to the lower back and upper buttock area, to the nerves, to the bladder, as well as the bowel in some certain circumstances. And we test, and having that constant current and electrical stimulation to the nerves that innervate the bladder, we hope to see if that can be able to control and kind of quiet down those nerves to cut down on urinary urgency or frequency or urge incontinence. The goal is for this is to be able to do that by 50% or more. So as you can see here is a two-step process where we implant temporarily the device, so we test it in the office, and then we can be able to proceed with testing over that trial period to see if it helps improve your urinary symptoms. And if it does, as in phase 2, we can be able to insert a little battery about the size of an Oreo cookie that rests right below the buttock in your lower back, upper buttock area underneath the skin, and can be able to pace, again, the electrical stimulation to your bladder to cut down your urinary symptoms. So that, in a nutshell, is the treatment for overactive bladder for urinary urgency, frequency, urge incontinence. In regards to the question that was raised earlier regarding what can we do in situations as it relates to younger individuals who have not undergone menopause or have not experienced childbirth, when we talk about overactive bladder symptoms, that can occur in any situation as far as age. It is not uncommon for us to see young men and women who have overactive bladder symptoms. We don't necessarily have a known etiology or cause for their symptoms or why they develop it at a young age or even in an older age. But menopause does not have a direct correlation, or does childbirth have a direct correlation with overactive bladder symptoms. And we can see them and actually treat them in the same manner as we are for patients who have gone through menopause or had childbirth. Believe that answered that question. In addition to addressing nighttime, waking up 3 to 4 times a night and restricting fluid intake, you have an access to be able to try all the other treatment options in those situations in young people. There are other causes of urinary incontinence. So we talked about the most 2 common causes of urinary incontinence, that's stress incontinence and then urge incontinence. But there are also a few others that we would like to highlight. One is overflow incontinence. That's a situation where your bladder just doesn't work anymore. So when we talk about urinating, the bladder is like a big muscle. And when you feel the urge to go to the bathroom, your bladder squeezes and allows urine to come out. And then as your kidneys are producing more urine, once you finish urinating, the bladder just relaxes and fills back up to a decent sizable volume. You can have situations where your bladder is no longer, for a variety of reasons, able to squeeze. And so it just sits there collecting urine, collecting urine, collecting urine. And over time, it gets to a point where it can't hold that. And we call that detrusor underactivity or outlet obstruction. There could be a situation of functional incontinence, individuals who have decrease in mobility, who have inability. I see it, I know I have to go to the bathroom, but I physically just can't get to the bathroom in time. Either I have mobility or my gait or my balance are issues, or I need assistance to go to the bathroom. And because they don't have that 24 hours a day, 7 days a week, they can develop urinary incontinence or leakage because they can't control it. Or there can be some cognitive issues after a spinal cord injury, after a stroke, after some type of condition which impairs their cognitive ability with age, Alzheimer's, all those place factors in related to what we call functional incontinence. And then lastly, although we won't go into great detail about this, there could be issues related to fistula. And what we refer to fistula is a communication between 2 solid organs. So it can be a connection between the bladder and the vagina, the bladder and a ureter, the bladder and the urethra, or it could be the bladder and the uterus, but there can be some connection with another organ, even bowels sometimes, where you have a communication and you have leakage coming up. And so that can be addressed, and that's a whole separate conversation, but that is another form of urinary incontinence. So next we're going to talk a little bit about overflow incontinence. And I use this as an example for my male patients. This is a very common situation that can occur in male population, as well as in females as well. But specifically, this scenario is related to men, where we have a situation where we have a normal prostate. And here we can see urine is traveling through the prostatic urethra, a part of the prostate. Men have a prostate, women do not have a prostate, and can be able to travel out, in and out of the penis. Here in this situation on the right, you see a man who has an enlarged prostate. And when you have growth of that enlarged prostate, urine is unable to pass within the bladder, out of the bladder, excuse me, and pass the prostate. And you have what we call an enlarged prostate, and you can develop urinary retention or inability to empty out the bladder. This is an example of our next slide where we see what happens over time when a situation where your bladder has not been able to really work effectively and efficiently. And over time, you see on the left, this is a normal bladder wall. Again, remember the bladder is made out of muscle, and that's a normal lining of the bladder wall. And then as we move to the right, over time, if it's having to work over against a resistance every time it has to go to a bathroom, some form of a blockage, over time it becomes hypertrophied or thickened or scarred or hardened, and it just kind of wears out with time. And this is a situation we can see where you get this very thickened, very inefficient bladder wall here. And in those situations, you can develop something what we call abnormal bladder wall structure. So this is an example. This is a CT scan or a CAT scan. This is showing the side view. You can see this nice anatomy of a patient's spine coming down. But then you see this large circular kind of structure towards the front of the abdomen here. And what we see here is a man who has an enlarged bladder, a very, very large distended bladder. And when we look straight on, we can be able to look that he has this very large prostate that's blocking the bladder. And this is an example of what we call overflow incontinence. If he's in a situation where he's not fully emptying out his bladder, but then he begins to start to have leakage. It's just spilling over of urine and not really fully emptying. The last part of this talk before we have any additional questions, and we enjoyed the questions, those were great questions, and we look forward to any other additional questions or conversation at the end of the talk. But the next section related to incontinence we're going to talk about is specifically related to post-prostatectomy stress incontinence. And that can happen specifically in men, and it typically occurs after having prostate surgery for prostate cancer. So that's a very known entity that can occur after having your prostate removed or having some form of treatment for prostate cancer, that men can develop urinary incontinence. Typically, that incontinence is related to stress. As Dr. Ajay mentioned, stress incontinence with coughing, sneezing, laughing, or physical activity. And that occurs when during the surgery or therapy for the treatment of the prostate cancer, the nerves and the blood flow to the control of your sphincter to keep your urine intact and not leaking is disrupted. There are two different treatment options. One is called an artificial urinary sphincter. An artificial urinary sphincter is a three-piece or three-component device that actually wraps around the urethra, almost like a blood pressure cuff, and it squeezes down on the urethra as a sphincter would to prevent you from leaking urine during physical activity. This is mimicking what your natural sphincter looks like that has been disrupted, unfortunately, due to treatment of your prostate cancer in most situations. There is a controller that's in the scrotum, and then there's a reservoir that contains fluid in the system. And literally it wraps around the urethra, squeezes down. When a patient feels like they have to urinate, they press a button, and that button is in the scrotum that releases the pressure off of the urethral cuff and allows urine to pass, and then it squeezes back down. It's an outpatient surgical procedure with a shelf life of roughly about 7 to 10 years, excuse me, and works very well for particularly men in treatment for stress incontinence. Then next, for patients who have slightly mild incontinence after having some surgical intervention or pelvic surgery, this is a male sling. Similar to what Dr. Ajay mentioned, in women, you can have a female sling, generally made out of mesh material, but in men, you can also have a sling that is placed and is used out of mesh material as well, that wraps around the urethra and really gives the urethra support that prevents you from urinating. Again, this is usually intended for mild to moderate or low moderate urinary incontinence, and this is another treatment option for men who have stress incontinence. That comes to the conclusion of our talk. I want to thank you, especially towards the end, and I apologize for my delay. Me and Dr. Ajay are here. If there are any other questions, feel free to put your questions in the chat and we can be able to answer them, giving you kind of a brief summary of what it means to have urinary incontinence and different types of urinary incontinence. So there's one question that I can go with. So if my bladder does not fully empty, is Botox the right medical therapy for me? That's a very good question. No, it would not be in certain situations. So if you have difficulty emptying out your bladder already and you don't fully empty, for most situations, we would not proceed with Botox for you. However, there is a subset of patients that we do. For patients who have, for example, a spinal cord injury or have some type of neurological disease process that causes them to have urinary retention, diabetes, Parkinson's disease, multiple sclerosis, spinal cord injury patients who are catheter dependent, meaning that they have some form of bladder management, whether they have a catheter that they insert into their bladder to drain the bladder, or they have a catheter that stays in their bladder 24 hours a day, 7 days a week. And those patients, if they have overactivity, their bladder is just so dysfunctional that it doesn't know what to do. It doesn't empty, and then it gets so active that it leaks. There are many times in those situations that we give Botox to be able to relax the bladder, knowing that that patient is going to stay with some form of a bladder management, usually having some form of a catheter of some sort.
Yeah, so I would just add to that, I think a really good option for this patient would be InterStim or neuromodulation. It is FDA approved for non-obstructive urinary retention, urinary urge incontinence, and fecal incontinence. So if your bladder does not empty and you don't have an obstructed prostate or an obstructed stricture or something that's obstructing you from emptying your bladder, sacral neuromodulation might be a good option to consider.
Great question.
There was one other question I answered, Gareth, and if you want to add on to my answer, how to diagnose new onset of urinary incontinence. So I said we usually start with checking for UTI, and if the leakage persists, first line is understanding whether it was stress or urge, and then we treat. So if you want to just add on to that.
I think that's great. There are some non-invasive testing that we can be able to do, and including checking for urinary tract infection. We can also check to see if you're emptying your bladder effectively. We can be able to have a conversation about your 24-hour fluid intake and see if their fluid management, it could play a factor. Sometimes we even get patients avoiding diarrhea to be able to keep track of their urinary symptoms. So essentially we compile all information, and based upon the symptom and the presentation and any other medical problems, we can make a diagnosis and kind of go from there to treatment. One other question I think just popped up.
How
How
is the first line course of treatment determined for urgent incontinence for an individual? I'll let you take that, Garrett. You wanna-
So our American Urological Association has done a wonderful job, including with urogynecology as well, about setting up a pathway or algorithm, if you will, kind of a template of a step-by-step approach for treating patients with overactive bladder symptoms or urinary urgency, frequency, urge incontinence. And they define them as first line, second line, third line, and there can even be some fourth line therapy options. But for our purposes, we consider first line therapy options as usually behavior modification. So non-pharmacological, non-medical options that we can be able to do to adjust lifestyle to see if that can help improve your urinary symptoms. And that discussed with time voiding, fluid intake, and restriction of certain fluids, particularly bladder irritants. So that is what we consider to be our first line treatment. Many of us, in addition to doing first line therapy, may also in certain situations add on second line therapy as well. And that includes pharmacological or medications. And then once we have entered the world of medications, and after that has failed, then we talk about advanced therapy options, which include Botox into the bladder or a bladder stimulator or tibial nerve stimulation. So it's that stepwise approach. Good question. Any other questions at all? Well, thank everyone who has come on. We really do appreciate you taking the time on this holiday week. This is, again, I'm not sure, Bladder Health Awareness Month. And so we wanted to take this opportunity to reach out, to share that information about bladder health awareness. Dr. Ajay, I don't know if you have anything else to add, but we welcome any additional questions. We've highlighted some contact information to our office if you have any further questions or concerns.
No, yeah, I just appreciate everybody taking the time to come out here. We've done a really quick overview, but there are some patients who are far more complex and have a lot more specific needs. And we really need to sort of sit down and go over your individual options in some of those patients. And there are bigger surgeries, bladder removal surgeries and what's called bladder augmentation, where we take a piece of bowel and add that. So you mean those are, much more complex surgeries, but we offer the whole gamut here. It just depends on whether you're a good candidate and whether you're interested in having bigger surgeries if these treatment options fail. So we are happy to discuss those with you as well. But yeah, happy Thanksgiving, everyone. And we're grateful that you guys are our patients and that we can help.